Hello, my name is Shawn Buckley, and I'm with the Natural Health Products Protection Association, and I'm extremely pleased to have Sonia Parmer and Alan Cassels as my guests today. They're both experts on the regulation of drugs, different aspects, and interesting enough, they also have had involvement working for or with Health Canada. So Sonia is the Vice President of Regulatory Affairs and Government Relations for the Canadian Health Food Association, which is the largest trade association concerned with natural health products and the health food industry. And she spends a lot of time dealing with Health Canada, but she also has a past with them, and I'll ask her in a minute to share with that, just so that you understand, where she's coming from. And then we have Alan Cassels, who is a very rare individual in that he's spent, decades of his career as an expert in drug regulation, not necessarily natural health products, but drug regulation, which is what we're dealing with. And he's also been, on some long-term projects funded by Health Canada, funded by the Canadian Institute of Health Research. He's been involved with federal and provincial government initiatives on drug research, and he's written and published 4 books on drug research. So I'm very pleased to have both of these guests, and maybe I'll ask both of you to just share with the audience how you came into this and kind of what your background is. And maybe we'll go Sonia first and then Alan.
Thank you. And thanks for having me. I'm very excited. Obviously the Canadian Health Food Association has worked very closely with the NHPPA on, consumer campaigning and just campaigning for natural health products and really preserving a right to access and to have fair regulation for these products. So a little about myself. I'm as you mentioned, VP of Government Relations and Reg Affairs, and I never had really intention to come outside of government necessarily. I think this was something that I had thought I was going to stay in for my entire career. I probably thought originally that I would work for Health Canada my whole life, but what had happened in my situation was that I did work for Health Canada for about 15 years. I originally started in a lab. I was testing vaccines. I did lot release testing as a student. I got engaged very early in on the drug side, mostly actually, and was asked to stay on. So I moved into many different categories over there at Health. So I worked in bringing the Cannabis Act into force. I worked in natural health products directly for a couple of years. I worked in GMP inspections for 5 years. And I also did blood establishment regulation and a bunch of other things kind of in between all that. So after that, I actually moved to Treasury Board of Canada Secretariat. So I was actually responsible for regulatory policy, regulatory modernization, red tape reduction, and really kind of managing regulators. So that's where I kind of really learned a lot more about, what a regulator is supposed to do, what rules they're supposed to follow. And then it just so happened that something came up at CHFA that really kind of looked interesting in terms of this role that I'm still in about 3 years ago. And what really drove me to coming outside government was that this industry was such a passionate industry. It was always an industry I had a lot of respect for in terms of the people working there. It's something that I believe in personally. And I always saw a very big gap between the interactions with this sector particularly and with government, and really kind of wanted to help bridge that gap, having worked in regulation and been a regulator, and then gain kind of insights on the outside and through industry. So that's really how I got into everything, and then never really kind of expected all of these changes to happen at once as they have happened. So that's it in a nutshell.
So Alan, do you want to share with us how you got into drug regulation?
So I spent my early part of my career as a naval officer. I was in the military for 12 years. And when I decided that I wanted to do something different, I went back to university, studied public administration, the master's level, and got offered a job to work on a drug research study in the very first month that I started those studies. And I thought, okay, this is going to be a temporary thing, and I'll do this for a while till I find something more interesting. But I never did find anything more interesting. So I've been doing drug research studies, so policy research studies now for more than 30 years, funded by Health Canada, British Columbia government, and some international organizations. The main thing that I've sort of discovered, so I'm really kind of focused on for the most part, on the art of prescribing. So looking at the quality of information that physicians and consumers get about drugs. And naturally, if you're going to study that, you have to understand how those drugs are regulated and how groups like Health Canada or the FDA approve products. And so I spent a lot of time, looking at that. Talking about the gaps there, Sonia, I mean, the main thing that I have spent a lot of my sort of journalism career doing was exposing the gap between what the science and the evidence says around pharmaceuticals and what the marketing says. And you can imagine there's always a story when you look at the differences between the way a drug is studied and the way it performs in clinical trials, and looking at the way it gets used in human bodies in the everyday world. And so that gap is always been fascinating for me. So I've written a lot about the exaggeration and the over promotion of a lot of drugs, and the way in which the marketing almost always over promises and under delivers when it comes to prescription pharmaceuticals. I should mention one thing, and I'm certainly not an expert in natural health products, though I know enough. I wrote a book about the history of the Cochrane collaboration, which is one of the early kind of fiercely powerful independent groups that looked closely at meta-analyses, of clinical trials to be able to come out with good information for consumers and physicians. And in the course of that work, you discover a couple of interesting things, but what's relevant to this topic mostly is the size of clinical trials. So when you think about and you look at the literature, say around the studies for something like cholesterol-lowering drugs, where they've got 5,000, 8,000 patients in trials, and you compare that to trials of natural health products. And so probably the best example that I can think of was done in 1747 by a naval surgeon named James Lind. And at that time, the British Navy, the biggest cause of death and disability in the Navy was scurvy. And he did a clinical trial that involved 14 sailors. And in the course of that several-week trial, was able to determine that there was something in citrus fruits that prevented those sailors from developing scurvy. Of course, we went on to discover it was vitamin C. I make this point because the bigger an effect that a product has, the smaller number of people you need to study it in. And this is really important when it comes to natural health products, because if products are really effective, you don't need trials with 5,000 or 10,000 patients. You can do it in several hundred patients often. And but there is a certain belief, both in the regulator and the pharmaceutical world, that the bigger the trials, the better. I would argue the opposite. The bigger a trial is, the less effective the product is.
Can I jump in for a second, Alan? Because you got me thinking about two things. I was involved in a trial where we were arguing about drug effectiveness, and so I had to bring in a bunch of experts, including one was Dr. Bonnie Kaplan, who for decades ran the behavioral research unit on behalf of the Faculty of Medicine at the University of Calgary, and this unit was based in Children's Hospital. A complete expert on different research designs. And she shared with me that there's a whole branch of science, like this gold standard of the large, random, double-blind clinical trials that perhaps we'll discuss this as part of the intellectual property rights game. So we're told it's the gold standard because it's not going to overstate positive results is the main reason. It's actually going to show if the drug works, if we can hit that magical statistical separation. And then I always say we pretend that means the drug works.
Yeah.
Even if it was a fairly designed trial, which you can't take that for granted at all. But she said, there's a whole branch of research that suggests that actually that's not true. Like, researchers disagree about whether or not a large double-blind, clinical trial actually gives you the best information. And, that led me to understand, okay, this is part of the game, because to get approved to treat any serious health condition, I'll stop there. But I mean, they're not going to approve natural health products for, any specific condition, unless we go through this new drug approval process, which requires large clinical trials, and no one can afford them because they don't have a patent. So it just seems to me, if we were going to put our tinfoil hats on and go, well, is this by design? Because I've worked in government. So, I've worked in Ottawa for Transport Canada. I worked in intergovernmental affairs in Victoria when it was a non-political branch during the Charlottetown Accord. I've worked in skills training and labor. I've worked for the Human Rights Commission. I've been in government, in policy departments. I understand how it works. And my belief is that when you have a policy that's been going on for a long time and deliberately reaches a result, that was the intention. And I appreciate, that sometimes things happen that aren't the intention. But for the last 100 years, at least, we have put ourselves in a position where only patented drugs get approved. So do either of you have any thoughts on, this gold standard thing?
It just represents the hegemony of the pharmaceutical industry. It's like we have the gold standard, and we're going to impose it on everyone else. It simply defies common sense and rational thinking. So, I agree with Bonnie Kaplan. I mean, there's different ways to study things, and if you say there's only one way, then you're automatically cutting out the competition.
Yeah, and just so that people understand, when we're talking about intellectual property rights, so if you invent something new, you can get what's called a patent. And in the drug world, a patent can last for 25 years. And as long as you have a patent, no one can compete with you. So, but you can't patent a natural health product.
Right.
So we're out of this intellectual property field. But the drug approval process is so expensive that unless you have a patent, you won't raise the money or spend the money to do it, because if you're successful, everyone else can just sell the same product without that outlay, and you will never recover the cost. Aside from the fact that I don't know of a natural health product company that actually would have the money in the first place. And so that's what we're talking about, is just, wait, we can't get approval to treat serious health conditions, but because we don't have intellectual property rights. Do you think that leads to good health outcomes when we structure our drug law so that it's only legal to treat specific conditions with chemical drugs?
I mean, maybe I'll jump in here as well, because I think from what we're really hearing from the trade and the industry perspective is that obviously there's not a lot of appetite to do clinical trials. They're very expensive. The funding is very competitive, and you're not necessarily seeing the same amount of interest in, funding this kind of work. So, and they're often not eligible for large drug research grants. Like, it's not somewhere that our industry is putting a huge focus. But what it then does also is really limits innovation, especially when we're competing with the United States. And something that we've brought up quite a few times is really the fact that there are actual policy loopholes that exist legally where Canadians can order much cheaper versions from the United States. It's a 90-day personal import rule. And so Canadians are turning to and in some cases it can be the exact same product that's sold here. It can be illegal products that's sold here, but they're turning to much cheaper options that aren't necessarily, where they're not necessarily able to compete in the same way. So whether it be through patents, whether it be through pricing, I mean, there's just so it's just so deeply entrenched as to how difficult it is to do business in Canada and to be innovative and to get funding to be able to do the work that we need to do to advance. So I think from that perspective, like we have really been pushing, the federal government to reconsider competitiveness for this space. It's something we've also said is, when you want to introduce very expensive regulatory changes, they've talked about introducing regulatory fees, fees to cost recover the work that it takes to actually review these products to get to market. And we can talk about, the frameworks and how expensive this is. But it's really disproportionate. Like the amount that they're wanting to charge for something that just makes its way through the US border, the Canada border is incredible. Like the amount of dollars that are spent by Canadians buying things that are totally essentially unregulated or unmonitored is shocking.
You raise a good point, and I'll just so that the people watching understand, the difference between the two. So prior to 2004, Canadian natural health products were, for all intents and purposes, unregulated. Now, Health Canada would say, no, you had to comply with the chemical drug regulations, but you couldn't. They were just too onerous and not appropriate for these types of products. So we were unregulated, and then we get these new regulations, which, for the first time, require us to go through licensing. So we have to prove they're safe, we have to prove they're effective. And just so you understand, so when you walked into a health food store prior to 2004, or went to a naturopathic doctor, that like everything you were getting was, for all intents and purposes, unregulated. I mean, if Health Canada became aware of adulteration or a problem on a specific product, they'd pursue it. But by and large, I mean, I think we had 80,000 products on the market at the time, no regulation. Now, that was the exact same situation in the United States. No regulation. You don't need government pre-approval. You don't have to get a license. And that's still the case in the United States. So in our regulations, I think, Sonia, you can correct me, but I think it wasn't until 2015 was the final deadline that you have to comply with having the license. So it's really been short term that we've had to get a license. And Sonia, maybe I'll ask you to comment on two things then. So what's happened to our cost for natural health products because we have to get licensed in this, I'll call it onerous because it is onerous, but the same products in the US don't have to get approved. And then also, if you could comment, I mean, has this made any difference, or can we demonstrate that our products are any safer than the same products we're free to access from the United States?
Okay, well, maybe just from the transitional perspective, I know that there was an allowance over a number of years because some of these products were drugs, some of these products were foods, like they were regulated in different ways prior to 2004 and the natural health product regulations coming into force. But what happened actually quite quickly was that already by 2013, they had actually, it was 2010. By 2010, they had already had tens of thousands of applications in backlog. So like this is a long history of the department trying to find ways to, evaluate this information. Like very early on between 2004 and 2010, there was a boom in terms of people wanting to come in, get their products licensed, follow the rules, do things, according to the way that the regulations were intended, which was really to provide a framework to be able to regulate these products. And so already by 2010, they had such a huge amount of applications in backlog that they actually created a set of regulations. It was UPLAR. It was basically the unprocessed licenses. I forget the exact title. I can look it up for you. But essentially, it was unprocessed license, a whole regulation set that was meant to expedite and get through their backlog. So by 2013, they essentially had removed that. And so they had created a class system. And so the class system was meant to be an effective way to get through and review these licenses, because we are the only country in the world that actually does pre-market approval before products actually hit the market. So in terms of, the amount of time and money that's costed, today this program stands at $51 million to actually run the program. That's what was proposed in their cost recovery proposal. And so if you, just for easy math's sake, multiply that by 20 years, I mean, that's up to $1 billion spent on this program. And, it's really built to be quite an expensive program in the sense that, actually having the number of employees and capacity to look at this in such detail. So when they actually built the class system after the UPLAR was essentially repealed, they had class ones, which were meant to be, monograph products. Essentially, there was a safety profile established. You could get your product marketed basically in 10 days, pretty reasonable. And then you had your class twos, which was like a combination of multiple class ones. And then you had your class threes, which was anything outside of monographs, essentially. And so when you look at that system, that actually was a system that makes sense. It was functional, and there wasn't so much emphasis on pre-market review. But what we've seen over the years has been that there has been quite an evolution in which it has become more expensive because more focus has been placed on pre-market. And so what we've really tried to put forward is that our industry is telling us that pathways to market is their number one issue. So getting something to market quickly is a huge concern for our industry. And so when you have to go through a very onerous and very time-consuming, very expensive process to deal with getting a license to get to market, which pretty much no other country has to deal with. In many other countries, they're foods or complementary medicines. They're not necessarily regulated in the same way that we're regulated. And so it becomes very expensive. But that narrative is very hard to debate because the way that it was really kind of intended when we talk about, the outcome-based regulating and what the purpose was, it really was to, protect Canadians, protect the health and safety of Canadians before something hits the market. But in reality, when you submit something on paper and you're not putting much focus on, what is currently being marketed, including things that are coming over from the States and through the border, that risk proportion is really like putting that much resource, putting that much energy and attention to a pre-market paperwork process doesn't equate to necessarily having a much safer outcome. And so what we're seeing is that, we've worked with experts. We had pharmacovigilance experts basically scour the internet, scour Health Canada's data in terms of, the safety and the claims around, how in some circumstances, part of what they were driving in terms of regulatory reform was based on these being unsafe, quote unquote. So in committee, we were hearing, numbers being thrown out like 700 adverse events or 1,000 adverse events between 2020 and 2023, for example, like in a 3-year time span. But when we actually work with those pharmacovigilance experts from Deloitte, and we do have a summary of that, we have multiple analyses that were put out on this and papers that were put on this. It was very difficult, first of all, to actually conclude that the natural health product was the cause. The data is messy. It's not very good because you've got, Canadians inputting in some cases directly. It's not always health practitioners that are putting the information in the database. And quite honestly, many of the concoctions were such that it wasn't just a natural health product being taken. So, for example, if you were on a chemotherapy product and you had cancer and then passed away, that may have been included in the 700 to 1,000 that they were claiming. So when it actually came down to the numbers, they really stated that only 3 were really natural health product only. It wasn't the 700 or 1,000 that was lumped into the serious or adverse event.
Can I jump in? Because
sure.
The perfect example that comes to mind of Health Canada really relying on poor data was Cava. So just so the viewers understand, so Cava is it's a plant and you make tea out of the root, and you can go to Cava bars in Hawaii and some countries like Fiji, their national drink is Cava. So I mean this is widely used, has been used for centuries, And it can be calming. It doesn't impair you, like you can drive and all of that, but it calms you. And Cava was on our market, and some lady died, and there's like, she's on a, had a whole bunch of problems, taking a number of chemical drugs, and the public health nurse sees some Cava on the counter. So all of a sudden, Health Canada restricts Cava, like just takes it off the market. And I forget now how many years it was, but it was a long period of time. And like, that is no data like that, but that is just no data. So, Alan, I'm just going to share a story, and then I want to ask you, do you think this drug approval process works, meaning that Canadians can rely on, if it's something's approved by Health Canada? I know you're laughing. That means it's safe and effective. And
you have no idea how bad it is.
Oh, yeah. So I want you to give us some highlights on that, but I'll just share quickly the story to give you. I'm in a Superior Court case with Health Canada, and it was a grind. And they brought in this expert. They hired an outside expert who was a psychiatrist that ran a company that got psychiatric drugs through this new drug approval process. And I was cross-examining this person for days. And at one point, the person starts complaining to me about how hard it is to get a new antidepressant through this process. And this is under oath, like I've got the transcript. And he says, well, I've got to give Health Canada 2 sizable double-blind clinical trials showing the statistical separation between the drug and the sugar pill, which we'll pretend means that works. Not even, if it was a good drug design or trial design. But he says right out of the gate, I run 8. Because his clients don't want him to wait. They want to get the approval. So he runs 8 to get those 2. He doesn't have to give Health Canada the other 4, Vanessa's law notwithstanding. I haven't seen any regs flow from that. And so, and those other trials could have been inconclusive.
Well, they definitely were. They definitely were, because
they could have shown the drug worked, but the safety signals were too high.
Yeah.
Or they could have showed the sugar pill worked better than the drug, But to me, if Canadians understood, okay, you're taking this antidepressant, that was, maybe the clinical trial was run for 6 weeks or 2 months. Oh, do you know it's not approved for any longer than that? Right. But your psychiatrist will tell you it won't even kick in and start working until after that. But you assume it's safe and effective. So can you comment for Canadians issues with that belief? Well,
that is, one of the major scandals that we discovered in the last few years is looking at the trials of antidepressants in children. And again, this was a case where there were 10 or 12 studies run on various antidepressants. Something like 8 of them were negative, which means they didn't work. 1 was inconclusive and 2 were positive. Well, they published the 2 positive ones, and they used that to market the safety of the drugs in children. That has since been exposed as the scandal that it has been. So physicians are operating under the impression that, Health Canada approved the use of antidepressants in children because they found them safe. Well, that's because they only looked at the 2 positive studies. The big picture of this is that we all hope that the drug supply, whether it's pharmaceuticals or natural health products, are safe to consumers. However, we are doing such a poor job at maintaining safety of pharmaceuticals under this regime that we've got. We have drugs that are on the market that carry serious black box warnings, and those drugs still get widely used. We have widely used drugs for, say, cholesterol lowering or for arthritis, and these drugs have known adverse effects, and the companies are often required to publish corrections or to publish warnings. Typically gets ignored by the prescribing public. We did a study, this is probably 15 years ago, and we took 3 major drugs that had Health Canada, like strong Health Canada warnings, restrictions on these drugs, and we did a survey of pharmacies in Vancouver and in Toronto, and we had a couple of pharmacy students who went around and collected the kinds of information that consumers got, and the message the strong Health Canada safety message did not even end up in the consumer-oriented information that the pharmacy was required to hand out. So even though you've got this kind of safety regulation, if it's going to affect the profits of the manufacturer, you can imagine that's going to be buried, or Health Canada is simply not doing its job in making sure that safety information for regulated pharmaceuticals is getting to consumers. If you're going to spend $1 billion in improving the drug safety supply, the last thing you would do would be to go after products such as vitamins or herbal products that have very clear and safe characteristics. You would go after them instead of going after actually the pharmaceuticals, which are causing most of the problems. I mean, there are estimates that, and there was a study done probably 25 years ago looking at the number of Americans who die every year from properly prescribed pharmaceuticals, and it's in the hundreds of thousands. It would be up in terms of the cause of death. It would be somewhere between the third and fourth largest cause of death is regulated pharmaceuticals. So if you want a safer drug product supply system, you wouldn't go after health products, you'd go after the pharmaceutical companies.
Now, you raise an interesting question, is so, the chemical drugs have a very high risk profile. No. And I think people do what works, especially when they have to pay for it. And for natural health products, we have to pay for that. You can't go to the government-funded healthcare system in any province. I mean, there might be the odd exception, but really it's the chemical drugs that are privileged. And yet I think it's like almost 80% of Canadians, on a regular basis are paying out of their pocket for natural health products. And that's because they work. And, this health show that the NHPPA is running, we're going to be calling people, many of whom are only alive because of these products, and others that really it's the difference between being disabled and suffering terrible and having a normal life. You kind of raised the question, is good drug or good health policy or good drug policy, shouldn't we be asking the question, how do we get the best health outcomes?
Yes.
And do we ask that question? I mean, and it's a rhetorical question, because when I speak to high ups in Health Canada, I complain to them, listen, you guys don't ask the question. When you're formulating these regulations, how do we get the best health outcomes? Because I would think likely if we ask that question, we would prohibit you from accessing a chemical drug with these high risk profiles until you've tried a natural product. Now, do you guys have any thoughts on how the questions we should be asking and perhaps how we could be approaching this?
Can I just give one example? So a widely used drug used to treat high cholesterol. These are statins, widely prescribed, now generically available, heavily marketed. Every cardiologist in the world is in love with them. Though when you look at the harm profile, now I won't use the term risk, I use harm. There's harm related to these drugs. A certain percentage, maybe somewhere between 15 to 20% of patients, will experience fairly serious muscle weakening and enzyme breakdown in their bodies because of these drugs. Yet there are a range of other ways to deal with your high cholesterol that are either non-patented drug or just simply lifestyle approaches. Yet when a person is diagnosed with high cholesterol, the first thing that the physician is going to do is prescribe them probably a statin, instead of saying, here's certain things that you could do or try that are probably cheaper, probably safer, and certainly aren't going to cause the harm that we know is associated for a certain number of patients taking cholesterol-lowering drugs, statins. How much education do physicians get in medical school around natural health products or dietary measures and so on? I can tell you it's virtually non-existent, but also furthermore, the training in pharmacology and in proper prescribing that happens in medical school is also vanishingly small and really worrisome. So you get young doctors who learn their prescribing from the experts and the specialists around them, and not from good, wholesome sources.
I think, in my opinion, to be honest, especially having worked in regulatory policy, like outcome-based regulating is actually meant to be a way to kind of future-proof, in a sense. So typically you design regulatory frameworks to actually be more flexible, because you know that in the future things can change. Like, just as an example, I mean, we ran a regulatory annual modernization bill, for example, in TBS. And something that was really important to look at there was things that were so outdated. Like, in some cases, a fax machine was actually written into law. So, you could see that there's a lot of flexibility that can be built into outcome-based regulating. I think what the scary part is sometimes is that when you allow that much flexibility, so let's say, I mean, as an example, Safe Food for Canadians Act was supposed to be something that was a little more gold standard. There was a lot more work with the industry at the time. They actually paused the framework. It took 10 years in total to develop, and that is a comparable time to the amount of time that was taken for self-care framework discussions to evolve. However, in the case of Safe Food for Canadians Act, there were pauses, there was reworking. Like, industry was at the table, and I think in this case we've seen that a little bit less. Like, there have been consultations, but we aren't necessarily hearing feedback from, okay, we've submitted comments, now what's actually being done with those comments? Like, there are a lot of people that need to be at a table to be able to develop a proper set of outcomes and regulations and laws and legislation. And I think the difficult part that we've seen is when you build too much flexibility, what I get scared of is then the actual interpretations of that down the line. And I think that's where most of what has occurred in terms of disconnects and issues with stakeholders has really been around interpretation. So I mentioned the class system before. There was a class 1, 2, 3 system when that was first, developed. I think there was a lot less hesitancy from the industry to participate in that, in the sense of, if I could get, my vitamin C and my simple class 1s to market in 10 days, it was a lot more competitive. But over time, again, things have shifted and changed, and the way that we interpret things, or when I say we, I mean the way that the government interprets things versus the way industry or stakeholders interpret things have changed. And so there has been a huge gap there. And so in a way, I see a lot of opportunity where we can widen and make things, a little bit more flexible and a little bit more vague. But then it also scares me, because then it's like, how is that then going to be interpreted in 10 years when it's extremely flexible, but that flexibility then gets, very technical at a ground level, where you now, become a very gray zone. And so I think, from my perspective, truly, to actually work through proper outcome regulating, you need stakeholders at the table. You need them there early, and you need them throughout a regulatory cycle or a legislative cycle. Like, you need them all the way through. And that includes post regulations, and when operations and regulatory management are a thing. Like, you need to be working with stakeholders always. And I think that's where we've seen a little bit of a breakdown, is that meaningful interaction with stakeholders has evolved over time. And, when the 2004 regs came out, there was a lot of implication from the sector. The people working at Health Canada had the experience. A lot of them were homeopathic doctors or naturopathic doctors. Like, they had the training necessary to understand what they were regulating. And I think that's changed quite a bit over time.
I wonder if either of you have thoughts. I remember years ago when, like, the federal government, so we just talk food, it gets ever stricter, ever more requirements. And I remember when the small abattoirs were being shut down. And so we were centralizing to large abattoirs. And I got calls from people that ran the small abattoirs to see if I would engaged in some court challenge over this, and actually learned that most of the people running these had like master's degrees from Europe, where you can get master's degrees on running things like abattoirs, and highly educated. And they were sharing with me, rightly or wrongly, that actually going to big abattoirs does not result in healthier food, and is way harder on the animals, which is something that's lost. Well, now this is probably 20 years ago. Well, now we're at the place where big food has gotten to the point where I don't want to eat it. I consider it so unhealthy, and it's become so uniform because the government stepped in the first place, where we now find ourselves in the situation where it's much more expensive and actually, frankly, difficult to, in my opinion, eat healthy, because we've created this big food machine. And do either of you have comments on that? Because it raises a good question as to, do we go too far? Like, this is the problem. It's always for a good reason, but we've ended up with basically commercial food that you might share my thoughts on.
I don't know what I would say other than, you should follow the advice of Michael Pollan, who says, eat real food. I think that the focus lately has been a lot on processed food, right? And the serious problems with, filling our grocery baskets with processed food that have a lot of fat and sugar and salt and unhealthy things in it. So how well regulated are these large processed food industries? I don't think they are very well at all. But really, it comes down to, you want consumers to have choice, but they should be able to choose to be able to buy their meat from a local butcher as opposed to, a big multinational. Isn't that right?
Well, it gets into the legal philosophical then, because that's the thing, is we find ourselves in a situation where we no longer have that choice. Like when we were moving into the natural health product regulations, and again, like, I'm challenged from just a philosophical perspective that the only legal things I can access, be they chemical or natural, are ones approved of by a bureaucracy. Mm-hmm. And I remember there was a master herbalist, Rick De Silva, very well respected in the industry, and he had a company called HerbWorks. And he would grow his own herbs, and he would also go into the forest and wildcraft herbs. Well, he couldn't. He was too small, and that was too difficult of an operation for him to even try getting through Health Canada with these new regulations. So he just closed his doors. Well, I used to buy his products, and I have to tell you, I found it annoying that I actually couldn't choose to buy products from a master herbalist that everyone agrees knows what he's doing, who wildcrafts herbs, for example. And it's just, I think we lose sight of the fact that we paint ourselves into a box then, and we've crossed legal philosophical questions, like, let alone from, do we get good health outcomes? But is this the type of world we want to live in?
Yeah.
I agree. I think also, just from the, again, looking over at the US, I think with the shift under, the Make America Healthy Again mandate and Robert F. Kennedy Jr. coming in, I really questioned where Canada would take, this whole narrative around, food additives and the safety of food, and, especially what our children are consuming. You can see that obviously in Canada, where we compare on, certain additives, Europe has a lot more banned than we do here. And, it becomes, in my mind, a huge question around, we also represent healthy foods. We don't just do natural health products, but it becomes a question also around, education and, how much people can afford healthy products anymore. We just went, for example, to a conference at the Food Bank Association of Canada, essentially. And what they were kind of talking about was how difficult it is to actually bring healthy foods into the food banks. And it really just shows how across Canada, across our entire nation, there's a struggle to get people to eat healthy. And it's a deeper rooted problem than just our set of regulations on food or on natural health products. Like it's a much bigger social policy question and a much bigger question, I think, in my mind. And I really had hoped that we'd be able to go in a similar direction to, where Robert Kennedy Jr. was headed with, making America healthy again, because there's just so much opportunity for our sector to bring, sustainable products and healthy foods to the table. And so for me, it's such a deep rooted debate around, how we can actually make a difference here and how we can actually get Canadians to eat healthy.
It's interesting. We've formed the opinion that, in Canada, Kennedy and anything to do with Trump is largely unpopular. But I think you're raising the point, what would happen if in Canada we were asking the question, how do we have healthier food? How do we get the best health outcomes? Like, we can talk drugs all we want, but a good diet is the number one factor for health. And we're not asking that question. Like, yeah.
And it's really, reflected in drugs for mental health. As you know, psychiatric drugs are among the most toxic, troublesome drugs that we use widely. Antidepressants, anti-anxiety drugs, antipsychotics. Yet there is very good research showing how nutrient deficiencies and so on can really play havoc with your mental health. There are companies, such as True Hope, that make products that are way safer than any antipsychotic that you would ever be prescribed. Yet those what does Health Canada crack down on them? At the same time, allowing physicians to prescribe among the most toxic drugs we have for people with the manic depression. It's just it really defies rationality when you've got relatively safe, easily accessible nutrient-based products that are way effective and much safer. But a person showing up at their physician with manic depression is going to get an antipsychotic. That's the way it works.
It's an interesting world we're in. Now, I just see that I've had both of you for quite some time, and this has just been a wonderful conversation. What I'd maybe like to do is just, very briefly, 2-3 minutes. Do either of you have any final comments on perhaps how we should start, or what questions we should be asking in the regulation of our natural health products and drugs generally? So just 2 or 3 minutes at max. Maybe Sonia, you first.
Go ahead.
Sure. Yeah. I mean, to be honest, Shawn, I think that, like I had mentioned before, that the fundamental issue has to do with stakeholders being at the table for conversations, like whether or not we're asking questions. I mean, I think you've asked really good questions about health outcomes, but I think no matter what the questions are, what the discussion is, the right people need to be at the table. And I think this has been the hugest gap from my point of view. I think there's huge gaps, within the government itself when it comes to blue sky thinking, in the sense of like how policy is actually formed and then operations on the ground. And like, I don't know if the disconnect always is necessarily at the policy level. I think sometimes it's layers of relationships and collaboration that needs to actually happen. And it's at multiple layers. It's within the government itself to make sure the right people are at the table and they understand what the policy objectives are. And then actually having stakeholders then be part of those discussions and working with operations that have to interpret all of this. Because I don't necessarily know that the breakdown is at, just the operation level, just the policy level, and it's whether or not those questions are being asked. To me, it's really a huge deal as to who's participating in those discussions. So that's really my perspective.
Yeah, and I would add further that if you're talking about regulation in the big picture, you want to focus on where the problems are. And the problems, as far as I can see from my perspective, are not with natural health products or with food. The problems are the inappropriate often unnecessary, often unsafe prescribing of regulated pharmaceuticals. And if Health Canada really wanted to, make Canada healthy again, they would bring out not just regulation but education of consumers and physicians about the harms related to many of the widely used pharmaceuticals, and then which the side effect of that is people would say or ask their doctor, what's safer? What can I try that is not going to cause muscle weakening or not going to cause a lifelong dependence like an antidepressant might? And so, I would say focus on the problem. The asking questions about the safety of natural health products and forcing regulation on them, that's a major red herring. It's like the problem's over here, which means you're not looking over here where I think the major problem is.
Those are good points. And for me, it's just simply, let's ask how we get the best health outcomes and see what flows from that. I have to say, feel honored to have both of you on. And I've really enjoyed the conversation. So on behalf of the Natural Health Product Protection Association, I'd like to thank both of you for attending and sharing with us today.
It was my pleasure. So
thank you. I feel like we could have talked for hours, Shawn.
Oh, I told you that's how it's going to work.